Hi, welcome to this new episode of the Neurology Video Journal Club. We're glad to have you here. First of all, I want to thank the American Academy of Neurology for the incredible organization of the Video Journal Club. We're very happy to be here. And a minor detail, this is the first Brazilian journal club of neurology. So my name is Fabricio Ferreira de Oliveira. I'm a neurologist from São Paulo in Brazil. I'm the executive medical director of the ELYSIAN Clinic and a medical researcher at the Federal University of São Paulo. And I'm joined here by my esteemed colleague who's going to introduce himself, Dr. Cronemberger Andrade. Please, Dr. Alan.
Thank you, Dr. Fabricio. Thank you to the American Academy of Neurology for inviting us. This is a great honor to be here. I'm a neurologist here in São Paulo, Brazil. I'm also a master's candidate in neurology and neuroscience here at the University of São Paulo. And so now we were talking about the paper Association of Long-Term Exposure to Air Pollution and Dementia Risk. This paper background points out that we have now evidence that suggests that air pollution is really linked to cognitive decline and dementia. Polluted air exposure might increase brain amyloid A beta deposition. This is highlighted in some studies with animals. And we have also evidence that points that homocysteine and methionine imbalance could lead to oxidative stress, to vascular damage, and this may have some implications for brain health. So the objective of this study was to see how do homocysteine and methionine levels can influence the air pollution dementia pathway, and what's the role for cardiovascular diseases in these interactions. This work is grounded on a cohort study with extensive air pollution data and dementia evaluations, and this is important also to highlight these facts. The sample comes from a population in Stockholm, Sweden. It's a district in the Stockholm County, and the sample had at the baseline 2,500 people with more than 60 years of age. The relocations around the city were accounted for, and they were followed each 3 to 6 years. So the visits at the research center included interviews, clinical evaluation, laboratorial exams, and occupational and retirement history of the participants. It was mainly done with a 3-step procedure. A senior neurologist had a final say on that, and the cognitive testing involved clock drawing, mini mental state examination, storytelling, and counting. And they used a DSM-4 criteria to diagnose dementia in these cases. So the cardiovascular diseases included with ICD-10 coding were mainly ischemic heart disease, heart failure, and atrial fibrillation. Air pollution was assessed measuring the levels of particulate matters with less than 2.5 micrometers of size, and nitrogen oxide levels were also measured using a gestational modeling emission inventory for the years 1990, 1995, 2000, 2005, and 2011. And we also had a serial analysis using non-fasting blood samples with homocysteine and methionine levels using mass spectrometry for that. The statistical analysis included Cox models for dementia risk. It was a 5-year PM 2.5 and nitrogen oxide averages for this period of time. So as a result, we have that 376 cases developed dementia during the follow-up. They were likely to be less educated, likely to be male, and retired with less than 65 years of age. And they had, on average, higher homocysteine levels. We also saw in this study that 70% of elevated dementia hazard for each unit increase in PM 2.5 over this exposure of 5 years. The higher homocysteine levels mediated or interacted with approximately 50% of the total PM 2.5 effect on dementia. But in contrast, elevated methionine approximately accounted for a 30% reduction in dementia hazard associated with PM 2.5 exposure, excluding this cardiovascular risk. So these findings related to dementia, it's very important to notice that were less relevant for nitrogen oxides than to PM 2.5 when these effects were compared. So also, even excluding incident cardiovascular conditions, these interactions remained. So this was also included in the modeling, and it was important to the results. What the paper mainly adds. So it highlights the association between long-term PM 2.5 air pollutant exposure and higher dementia risk. Homocysteine and methionine really play a role in modulating effects of air pollution on dementia. So this is an important result to highlight. But we have some limitations. Potential limitations mainly involve the air pollution assessment because some participants were located, so it's quite hard to do this in practice. It's also an observational study with no biological characterization of dementia subtypes, so just some limitation. So we have important implication for clinicians within this study because as a result, we see that environmental factors are important and could be considered in dementia risk assessments. And we see that elevated homocysteine may serve as a potential biomarker for dementia risks if the exposure exists. So what comes next? It's important here to understand the mechanisms around these interactions and to explore future interventions to see if reduced air pollution could improve brain health. Okay, thank you for your attention. Now we will start the discussion around the paper. And Dr. Fabricio, I want to ask you a couple of questions because we see that there is really evidence linking air pollution to cognitive decline and dementia risk. What do you think about this particular study in comparison to what we find in the literature?
Well, several studies have been conducted in the literature in different populations as well. And some of them are references of this article, and they're very interesting. And they show that most of them show that air pollution causes cognitive decline and may increase the risk of dementia. This is not a universal finding, but the systematic reviews usually point towards the harmful effect of air pollution on cognitive decline and dementia risk. A few studies have also shown that according to the distance that people live regarding a highway or a place where pollution is higher, people can have more or less cognitive impairment according to that distance. So if they live near a highway or near a very polluted area, they can have more cognitive impairment than those people who live farther from those regions. In conclusion, we know that air pollution may increase dementia risk and cognitive decline. But we don't know if interventional studies, if interventions to reduce air pollution can reduce cognitive decline and reduce the risk of dementia. So that's a good idea for future studies, future interventional studies in which reduced air pollution could possibly lead to favorable results. And also future studies showing the interactions between air pollution and the homocysteine and methionine pathways combined, maybe through dietary factors, along with interventions to reduce air pollution. This could be good for brain health of the participants.
There's also one part of the study that they included the role of ApoE carriership on dementia risk. What do you think about this interaction, and what is the importance for this study?
I think it's very interesting because this was a very complete study. They assessed several factors, several variables that are not assessed in all studies, such as when the participants retired, the level of physical activity, creatinine, but they also assessed ApoE4 carrier status. And that is very important because we know that ApoE4 carrier status is the most important genetic risk factor for early onset of dementia due to Alzheimer's disease, and also other dementias such as vascular dementia, Parkinson's disease dementia, dementia Lewy bodies. It's also important for behavioral features in these dementia syndromes. It's important for risk of dementia. And even though it does not affect frontotemporal lobar degeneration the same way that it affects these other dementia syndromes, it's important that the authors took that into account because not all articles take that into account. One of the problems of the article is that there was no stratification according to dementia subtypes. So maybe a few patients could have converted to frontotemporal dementia, and so ApoE4 carrier status would not have made such a difference. But anyway, I think it's more important to have ApoE4 carrier status as a variable for conversion to dementia in general, than not to have it and miss that factor, which is very important for the dementia syndromes that I mentioned, such as Alzheimer's disease dementia, dementia Lewy bodies, Parkinson's disease dementia, and vascular dementia. Well, I think that concludes an initial discussion. So we should discuss now what this paper actually adds to the literature on the subject. So Dr. Alain, if you could please comment on that.
Thank you, Dr. Fabricio. There are some strengths I see here in this study because we have like a moderately large sample. It's a longitudinal follow-up, so it really adds to the literature. The relocations were also accounted for. So when participants moved around the city, it was also included. So the researchers measured the PM 2.5 and nitrogen oxide levels in the other.
I'm going to briefly comment on what you said about longitudinal studies. Well, it's very, very important that you mentioned that this was a longitudinal study because it can assess some cause-effect relationships, which is different from cross-sectional studies that do not have that ability. So this is a good advantage of this study. I agree with you.
Yeah, and also, Dr. Fabricio, the relocations around the city were accounted for. So the researchers were able to measure levels of PM 2.5 and nitrogen oxides in the new address of the participants. So it's quite important, and also this consideration for both PM 2.5 and nitrogen oxides, and both serum homocysteine and methionine in the analysis at the same time. So these effects were also composed in different pathways involving these serum rates, the direct effects, the indirect effects through mediation, the interactive effect with these variables, and also the effects due to both mediation and both interaction. So this is quite remarkable also. So this is a really important strength. So the analyses were also repeated after excluding those with cardiovascular diseases during the follow-up. So this is quite important because we know that vascular risk factors could play a role in these interactions. So the exclusion of these effects were also important. And also we had like the secondary analysis considering ApoE, carrier status, sex, food intake of both folate, and vitamin B12. So this is important to be considered, and mainly because this could change the methionine and homocysteine balance. So this is also a strength. But there are also important limitations here, Dr. Fabricio. What can you highlight about limitations for this particular study?
Well, air pollution was assessed every 5 years. For a city like Stockholm, that could be relevant, but depending on where you are, the levels of PM2.5 and nitrogen oxides could change before that. So a more frequent measurement of these air pollution levels could be important for studies in other cities, such as here in São Paulo, where pollution is very prevalent around the city. The assessment of engagement in physical activities may not reflect the actual level of inactivity of the participants. Actually, it was, in my view, a very superficial assessment of physical activities, physical engagement, and a more thorough assessment could be important. But since the authors also assessed several other factors that could interfere with their results, I think that the study was strong enough for its aims. Another limitation is that there was no stratification into dementia subtypes. And that's important because the effects of air pollution can be different according to the dementia syndromes. We don't know the exact mechanisms involved. So if air pollution is mostly involved in amyloidogenesis, then those dementia syndromes that have amyloidogenesis as its main mechanism could be more prevalent in places where air pollution is higher. If other mechanisms are involved, then maybe those dementia syndromes that involve amyloidosis might not be so relevant for this study. So it's important in the future that we carry studies considering the dementia subtypes and how prevalent they were after the assessment of air pollution. Well, I think it's very important that we consider the limitations of the study, but now I'm going to pass the word to you because I'd like to hear from you what you think are the implications of the study for clinicians. How do you feel that the study can add to our assessment and maybe even to future interventions towards our patients?
Yeah, it's quite interesting thinking about this, how this environmental factor, Dr. Fabricio, because I think we really should consider now including these kind of factors around the dementia risk assessments we do in the clinics. So maybe we can have like some risk factor assessments using maybe improved calculators or maybe other kind of tools that could really introduce these assessments, these risk assessments. And another practical implication I see that we can measure homocysteine levels. So elevated serum homocysteine may serve as a potential biomarker. Why not? So if the exposure exists, maybe including these could be useful to assess risk beyond risk for cardiovascular diseases. But no evidence so far saw that reducing air pollution and serum rate homocysteine in methionine could slow cognitive decline or maybe reduce dementia risk. So I think it should be taken with caution, but the potential is here on the table. Now I want to ask you, Dr. Fabricio, about this future implication. In your opinion, what comes next? What comes next in air pollution and dementia path and studies?
Well, I think you perfectly pointed out that the study showed that air pollution interacts with the homocysteine methionine balance to increase risk of dementia and cognitive decline. But that doesn't mean that reducing air pollution or improving the balance, reducing homocysteine, could lead to less cognitive decline and less dementia. So we need future interventional studies that can actually prove that. This current study that we're discussing is an important first step. It's a very thorough study. It's a study that considers several factors that can affect the aims that the authors search for. But in the future, if we have interventional studies showing that, for instance, reducing air pollution reduces cognitive decline and dementia risk, then we have another evidence that air pollution must be reduced faster than we actually believe it should because of other complications such as lung cancer or myocardial infarction and everything else. Another important intervention that could come in the future is to supplement folate, vitamin B12, vitamin B6, to see if the reduction in homocysteine can lead to less cognitive decline and reduce the risk of dementia. That has not been completely proven for other diseases such as stroke. The evidence in the literature is controversial for stroke. So we know that supplementation of folic acid and vitamin B12 or vitamin B6 can reduce homocysteine, but there's no straightforward evidence that reducing homocysteine, these patients have reduced risk of stroke. So we don't know what happens for dementia. And in the future, maybe these interventional studies can clarify that for us. Still in the subject of what comes next, we need more basic science studies to explain if the effects of air pollution and the serum ratio, homocysteine methionine, cause amyloidogenesis, neurodegeneration, atherogenesis by oxidative stress, for instance, endothelial dysfunction, or a combination of such mechanisms. We don't know which mechanism is more important here. There are some animal studies showing that when these animals are exposed to air pollution, they have more amyloidogenesis. But we don't know that if that translates to human beings. And we don't know if that's the main mechanism. So that's an important subject for future studies, particularly concerning basic science. And we also need to replicate these findings in ethno-racially diverse populations, because as the authors pointed out in the study, this population from Stockholm is a population that is mostly wealthy. There's no racial diversity there. And we need to know if in other populations the same results could be reproduced. So these are important next steps for the future. It was a very interesting discussion. I want to thank Dr. Alan Cronemberger Andrade for being here with me. I want to say a huge thank you to the American Academy of Neurology for this opportunity. It's really enlightening to be able to discuss such an important study and such a well-conducted study from Sweden. And I hope that we can have future opportunities to attend these neurology video clubs with equally important studies that may add to the literature and to our knowledge to benefit our patients. So thank you very much, and thank you all for watching.